Right, so we're down to the nitty gritty now. It's time to intubate the patient. Now, whether this is in cardiac arrest or in the context of an RSI may affect the position that we can get the patient into. But the technical process of intubation remains really similar, with the teamwork being absolutely key. Now, I can forgive you all for thinking that this is by far the most important of all of today's talks. And whilst there are loads of excellent bits in here that we're really keen to share, we can't ignore the fact that being excellent in managing the environment, choosing the best equipment, picking the best drugs for your patient, and optimizing their physiology in the context of an RSI, and being absolutely fastidious about positioning can all hugely influence laryngoscopy and make a potentially difficult task relatively easy. But the focus of the next few minutes is to try and make laryngoscopy itself even easier, despite all of those cheats that have preceded it. So first up, we need to make sure that we've discussed the plan and the approach that we're going to take as a team. We'll talk about cardiac arrest here to start with, and then consolidate on that by running through an RSI towards the end. And we'll be talking about the two options in this section of direct laryngoscopy and video laryngoscopy with a standard geometry blade. But we'll start off with direct laryngoscopy. Again, a bit of a broken record here, but as good as your technique is going to be, I don't think we can overemphasize how important excellent positioning is for this. Because after all, direct laryngoscopy is about altering those planes and creating a direct line of sight, and most of this is actually achievable without a blade in their mouth. Now, we've ventilated the patient via a face mask or via a supraglottic to try and give them some oxygenation during their cardiac arrest before we're going to intubate them, and then at this point we're then going to proceed with our technique. This section is going to focus on the operator 1 role, or the laryngoscopist, but debatably the operator 2 role is just as important as this operator 1 role, and we'll come on to that in a later section. When it comes to laryngoscopy, Levitan has described the process of being epiglottoscopy, laryngeal exposure, and tube delivery. Now, this is really useful because what it does is it splits up this skill into really small parts that help you slow down the process and keep orientated to these more simple steps. When you watch clinicians practice their technique in the cadaver lab or intubating on real cases, both pre and in hospital, it's really rare to see people intubate too slowly. The process is normally too fast, and when this happens, orientation to where they are is lost, and this can really hype up the stress of the situation, and then the escalating loss of orientation eventually leads to an unsuccessful attempt at intubation. And this is why breaking down the process into these 3 steps really helps slow it down and achieve what you're trying to do. So let's have a look at the whole process. So here you've got the blade entering the right side of the mouth, creeping down to find the epiglottis. Then it lifts up the epiglottis, revealing the larynx, and you can see a really good view of the cords. In comes the bougie through the cords. Then the tube's going to be mounted on top of the bougie. It's going to be slid down between the cords, rotated at the level of the cords so that it doesn't catch, and then advance through the cords into the right position. And then the bougie is going to come out at this point. It's worth having a look at that externally again. So again, direct laryngoscopy. So operator 1 takes the blade, puts it into the right side of the mouth, sweeps the tongue over the left to create some space. Then they're going to creep down to find the epiglottis. Then they're going to lift the epiglottis to reveal the larynx. Then the tube goes onto the bougie, an exchange of the tube for the bougie between operators. Down comes the tube through the cords, rotated through the cords, passed through to the right distance. Then the bougie comes out when operator 1's happy. Then it's going to be air into the cuff. Then on with the bag valve mask to provide some ventilations. Most importantly, looking to see that you've got end-tidal CO2, looking for rise and fall of the chest and for misting of that tube. So that all happens pretty quickly, and again, that's why it's really useful to try and break these parts down into smaller bits. So let's start off with epiglottoscopy. First of all, you want to get decent access into the mouth for your direct laryngoscope blade. So this can be done in two ways. It can be done by scissoring, which is where the operator one uses their thumb and index finger to push the mandible down with their thumb, and then with the index finger to press against their upper teeth. And this is really helpful in providing the space that we need to get the blade in if operator two doesn't have free hands to help at this point. And this is a really useful way of creating the space in the mouth. The alternative is operator two could just bring the mandible down. Then with the DL blade that James has described, we're going to use it to enter the mouth on the right hand side to sweep the tongue over to the left side of the mouth. We'll then orientate back to the midline not to get lost, and the uvula acts as a good landmark for this. And we're going to creep down the tongue to find the epiglottis. So this is epiglottoscopy. Now it's time to reveal that larynx. To make this as easy as possible, we want our blade placed in the centre of the vallecula, which is the space just in front of the epiglottis, and we've highlighted here in red. In here is the hyoepiglottic ligament, and by placing the blade into this, that helps actually lift the epiglottis forward to reveal the larynx. And then we're going to lift the laryngoscope towards an imaginary spot, 45 degrees, in between vertical and the patient's feet. This force is then going to help really reveal the larynx, so laryngeal exposure. Even if you've done everything right to this point, there are different grades of views that are going to depend on a multitude of different factors, and the views are Cormack-Lehane views. This diagram shows the view that we're talking about at laryngoscopy, with a grade 1 view on the left being the best sort of view that you can get with a full glottic view. You can see all the chords there, all the way through to the worst possible view that you could get on the right hand side, which is a grade 4, when you can't even see the epiglottis. Now, some of this can be due to patient factors and the anatomy of the patient, and we won't always be able, even if we're optimizing our view, to get a grade 1 or a grade 2 view. But excellent technique and all the other factors that we've discussed helps us optimize this view to be the best that it can be. And it's really important that we try and do that, because the better the view, the lower the number, the easier it's going to be to successfully deliver that tube. Now, we can try and optimize things further by using techniques like external laryngeal manipulation or ELM or head lift. And it's really important to do this because, again, we're trying to optimize the view to make things as easy as possible. And once we are happy that we've optimized the view as much as we can do without taking excessive time to do so, and that's really important, then we're on to tube delivery. Now, there's some really good literature, especially from Driver, that supports the use of a bougie in an emergency intubation, not just as a rescue, but as a planned technique to increase your first pass success. So we'll be recommending using a bougie here pretty much every time without exception. Now, keeping our eye on that view that we've just worked so hard to get, operator one will be asking for a bougie, and it needs to be delivered into their right hand without them taking their eyes off the view that they've just worked so hard for. Because if they rotate round to the right hand side to look for equipment, look for bougie on the tube, then there's a significant risk that they're going to lose that view. Now, once they've got the bougie in the right hand, they're then going to direct that through the cords. Once it's through the cords, they're then going to ask for the tube to go on. The tube is then advanced down to the level of the cords, and then you rotate it just counterclockwise to take the sharp bevel of the tube off the cords to allow it to pass easily, and then it's advanced through there. Clearly, we've got to make sure that it doesn't go too deeply into the airway, because most commonly it can end up in the right main bronchus, and there are almost always black lines on those tube which will depict the depths at which the tube should sit between the cords, and that will be dependent upon the manufacturer that you use. Then, when operator one is happy that the tube is in the right place, they ask for the bougie to be taken out, leaving just the tube in the right position between the cords. Then the cuff needs to be inflated, ventilations delivered, and the position of the tube and adequate ventilations confirmed. And this is so important. So the gold standard to confirm the correct position of the tube is to see a capnography trace, which coincides with ventilations via your bag valve mask. As we said, people also look for misting of the tube, equal rise and fall of the chest, plus auscultation. And you want to check saturations, but obviously that's not going to be possible in the context of a cardiac arrest. And we can't really overemphasize this, because tubes going into the wrong places have killed people. So if in doubt, pull it out. And essentially, without an end tidal trace, that has to happen. Also a personal opinion, but I would say that it's only at this point of actually confirming that you're in the right place is it worth taking the blade out. Because if there's any fine adjustment, such as you've gone a little bit too deep, you need to withdraw the tube, you need to do that under direct vision. And if you've taken the blade out, that's going to be a right faff to try and get that back in there. So you might as well establish that you're in the right place at the right depth, and only then at that point take the blade out. You then need to take note and state to the team the length that that tube is at the teeth, because that's going to be a really important reference point for checking the tube doesn't migrate at any point, even when you've secured it into place, which is what you're going to do now within whichever fashion you do within your service. So probably with either a tube holder or a ribbon to tie that in. So that's a bit about direct laryngoscopy, but what about video? And we're talking here, as I said, about a standard geometry video laryngoscope, so not one that's got a very significant and exaggerated curve on it. That is a different talk completely. Well, essentially, the sequence is the same, but the way in which we use the equipment can differ. Now, some people talk about using a video laryngoscope as a direct laryngoscope, so just looking in the direction of the green arrow at all times, and therefore obtaining a direct view of the chords. And then, if that doesn't go so well, then just having the screen as a backup if you're struggling. Now, I used to use this method, but the issue is that you're not really using the device the way that it's designed. And that is in gaining a better view by looking round the corner with the camera, which means you need to look at the screen rather than direct sight. To make matters worse, some video laryngoscopes, especially those with disposable blades, have really thick blades. So trying to get a direct view with direct sight actually becomes even more difficult than if you were just doing it with DL in the first place. So it's not really giving you the added bonus that you want. It's not impossible to use a video laryngoscope in this way, and it can be really useful to teach people to do direct laryngoscopy by the supervisor actually being able to look at the screen. But if I was choosing what I would want to do, personally, I would use a video laryngoscope as a video laryngoscope. What you also want to do is have a look at the blade itself and to see if there's a tongue channel. Now you can see here that with the direct blade, on the left hand side, that the red arrow shows the channel that you're going to use to sweep the tongue and collect it over to the other side of the mouth to create some space. Now with the VL blade on the right hand side, where the blue arrow is pointing, you can see that there isn't a channel to sweep a tongue. So some would argue that it's going to be a slight tweak in how you're going to use this VL blade, and that you might as well approach via the midline, because you're not going to be able to sweep the tongue out of the way. Therefore you can stay more easily orientated to the center point. So to use a video laryngoscope, a bit like direct laryngoscopy, you want to ensure that operator one never has to rotate their body round towards the kit, that their eyes, head, shoulders all remain lined up in the direction of the target. First of all, you place the blade in the mouth by looking at the mouth on the green arrow. Then as soon as you've orientated yourself to the blade being in the midline, then your eyes come down to the screen onto the purple arrow. Again, don't rush, creep down with the blade with suction ahead of the blade if there's any secretions at all or blood and vomit, to make sure you don't obstruct the camera. And I think you need to have a really good justification here as to why you're not going to use suction in an emergency unprepared airway. Again, it's the same process, so epiglottoscopy, laryngeal exposure, and then when you're ready for the bougie, you're happy you've got the best view that you can get, then you put your right hand out to receive the bougie. Looking down on the green arrow, just orientate the bougie into the mouth, and then it's a flick back to the screen to look at the purple arrow again, and then guide the bougie through the chords. So just running through that in the video, here's the midline approach with the blade creeping down. We've got into the epiglottis, we've got epiglottoscopy, we've got laryngeal exposure, we've got a really, really good view here, a grade 1 Cormac-Lehane view. Then the bougie comes in through the chords. We're going to ask for a tube to go on top of that. That's going to come down from operator 2 to operator 1. It's then going to be advanced along the bougie until we get to the chords, and then we go a little rotation round to get the bevel off the chords. Then through the chords, the bougie's going to come out, and then we're going to check that we're in the right position, that we've got in tidal again, and all the other checks. Okay, so now we're happy with the process of intubation, both from a direct and video perspective. How do we add this into the mix of an RSI? Well, the good news is that there isn't a huge amount of difference, and it's just building upon what we've just been through and talked about to this point. Once the checklist is done, the main difference is going to be that we'll be putting drugs in and waiting for them to work before proceeding to intubation. We've been through the pharmacology now, and we know that the paralytic is going to help us get the best view, relax those cords, relax the muscles around the airway, and we need to make sure that we actually wait long enough for them to work and don't rush to get the tube in. And conventionally, that's around 60 seconds for rocuronium, and then you're going to check that the jaw is relaxed. With an RSI, we're going to ensure that we pre-oxygenate or denitrogenate them for several minutes beforehand with high flow oxygen and a well-seated mask, again, to give us the best possible chance of having a good look without physiological complication. Now, historically in an RSI, we wouldn't have ventilated through apnea, so from the period of giving the drugs, waiting for the paralytic to work before we then go on to intubation. So we're basically sitting there whilst their oxygen levels are dropping down and down. But that changed, and mainly I think because of a paper in 2019 from Casey that moved things forwards. Now, they saw that ventilation through apnea didn't cause the increase in aspiration rates that people were worried about by you ventilating through the apnea in a non-starved patient. Also, that these ventilations helped avoid critical hypoxia. So you'll provide these ventilations in apnea with a two-person technique, low volumes, low pressure ventilations whilst they're apneic. And that then saves that frantically hurrying at that 1 minute mark to go because they've been apneic and we're worried about leaving them for any longer. We can do it in a much more collected and calmed way. So let's just talk through the process. So as always, they're positioned really well. The drugs have gone in by this point and they've become apneic. We're ventilating them through the apnea. Again, low volume ventilations, low pressure, two-hand technique over the face mask, and those gentle ventilations. We're going to be using direct laryngoscopy here. Okay, so we're to the point now that the patient's nicely relaxed, the jaw's nice and relaxed for up to 60 seconds at least. I've actually got the reassurance that we can ventilate, which is great. They look very relieved. Okay, the blade comes from operator 2 over to operator number 1. Goes in the right side of the mouth, sweeps the tongue out the way, epiglottoscopy, finding the epiglottis, revealing the larynx. Across comes the bougie. Operator 1 stays eyes on the view at all times, not rotating away. Then the bougie comes through the cords, tube onto the bougie. Tube's then down into operator 1's view. Then that's inserted. It's rotated at the point of the cords, through nicely. Happy we're at the right point. Not too shallow, not too deep. Bougie then comes out, laryngoscope stays in, air then goes into the cuff, nicely inflated to the right pressure. On goes the circuit, catheter mount filter, end tidal, bag valve mask, ventilations. You can see immediately that the tube is misting. You can see that the chest is rising and falling. We're going to have an auscultation again in a minute, and we've seen the end tidal is there. We've confirmed the tube placement. Happy with the depth of the teeth. And then we're going to secure it into place.
Oh, nice to see you two having a day out there. That was a lovely little video of you both. You seem very happy together. Good. Anyway, back at the ranch, we need to answer a few more questions, I'm afraid, Simon, if you'd be so kind. Now, you mentioned earlier about improving the view during laryngeal exposure with that head lift and external laryngeal manipulation. Can you talk a little bit more about those? So go into a little bit more depth for me, Langers.
Oh, go on then. Okay, well, people have historically talked, haven't they, about what you do if the first view doesn't result in successful intubation and what you can really change in your next attempt. But things have moved on a bit from that, and it's now a bit more of a dynamic response to what you're finding when you then don't get a satisfactory view to proceed with intubation or when intubation fails. And it doesn't matter which order you do these in, but the two things that you can be thinking about are external laryngeal manipulation or bimanual laryngoscopy or a head lift. With ELM, when you've placed the blade and you're performing either epiglottoscopy or laryngeal exposure, you can then put your right hand round, put your thumb and your index finger and your middle finger maybe onto the larynx and move the larynx to see whether or not it can then be brought into a better position or view. It doesn't always work, but very frequently it can make a big difference to the view that you're getting. But I know what you're thinking now. What on earth do you do when you've got your right hand on the front of the neck and then your left hand is on the laryngoscope? Because my third hand isn't very well trained. We certainly haven't been through it in the technique. But don't worry, there is a workaround for this. So then you can ask operator 2's hand to come over and essentially put their finger and thumbs over where yours are on the larynx and try and maintain that position of ELM. Now, obviously, there's a risk that it's going to move, but it is definitely a technique that can result in an intubation that was otherwise not possible to perform. The other thing that you can do, as we've mentioned, is a head lift. Now here, again, the blade is in the mouth and you're either performing the epiglottoscopy or laryngeal exposure and you haven't, again, got the best view. The intubator can then slide their right hand under the occiput and lift the head to bring the larynx into a better view. Now, you can see how this happens here on this video, and all that is happening to change this is that the intubator has got their hand on the occiput, lifting the head, and you can see the massive difference that we've got here in the view that is obtained. One which is pretty much non-intubatable and one which looks like even I could get the tube in. Now, what do you do again? You've tied up your right hand. I can't make a joke about the third arm again. So at this point, you can use your blade in your left hand, obviously, to maintain that position as long as you've obviously got it into a decent position in the mouth. You then bring your left elbow in really tight to the side of your body into a strong position. It's flexed at 90 degrees. And you can imagine then you can maintain that position that you've used your right hand to hold the head into, and then go for the bougie and then deliver the tube. So what we're saying here is that there are two things. There's ELM and there's a head lift. And really drilling these when you're practicing intubating, either on cadavers or on mannequins, is a really good thing to do, because you'll find it then slips into your standard practice and then you really are optimizing your first view.
Yeah, very impressive. Good stuff. Yeah. The other thing I wanted to ask a bit about was, what I wanted you to tell me about specifically, Simon, is tell me about suctioning and intubation. Now, I know about suctioning, but what about this leading with suction with video laryngoscopes? What's that all about?
Well, obviously, with video laryngoscopy, there is a very precious end of that camera which is being delved into the mouth of the patient. And there's obviously lots of nasty things which can try and stop that camera working. So stuff like saliva, blood, vomit, and even in not heavily contaminated airways, if you're going to get any of that on the end of the camera, then that's essentially your video gone. So you need to have a really good think before you're intubating that patient about why, if you're using video, and in fact, actually with direct as well, why you wouldn't want to have suction in your right hand and really clean up that airway. Certainly in those post-rota patients that have had those eye gels down for a bit and they've got quite irritated, bit of blood there, bit of saliva, even if they're not a patient that's been vomiting, creeping down the tongue with that laryngoscope with a good suction catheter, so something like Decanto, ahead of the blade and certainly ahead of the camera, really clearing that view is a great way to ensure that you have got a good view and you're not getting contamination in the camera. And there are not perfect studies out there, but some good studies that support the fact that even in these high-risk soiled airways, the use of video laryngoscopy is really quite safe to do. And with the right sort of blade, so a standard Macintosh contour blade, which hasn't got too wide a profile, you can obviously try and revert back to direct if the worst were to happen at that point as well.
Yeah, very nice. Makes total sense to me. Okay, so before I let you off the hook and before everyone else gets to listen to someone else talk, thankfully, I've just got a couple of other things I want you to clear up for us, both related to bougies though. So are there any problems you can get when you are trying to pass the bougie in the first place? And secondly, if you can cope with two questions at once, can you get any problems when you're trying to pass that tube over the bougie? So when you're trying to pass the bougie initially and when you're trying to pass the tube over it.
I think one thing that we've really got to be aware of is the tip that we've got on a lot of the bougies, that coude tip, which when you've passed it through the cords, just remember it's got that angle, hasn't it? And it's very possible to get hold up on the tracheal rings. So normally when we're passing the bougie, we talk about, oh yeah, I could feel the tracheal rings when I passed that through, because that's a nice bit of reassurance. But just remember that it can easily abut that, so you can get hold up. So what you need to do is, if you've got the bougie through the cords and you can't quite work out why it's then not advancing very far, is not just to put more pressure onto it, but again, a bit like we do with the tube, a little rotation, either clockwise or counterclockwise, 90 degrees, to take it off those tracheal rings, to then be able to advance it a bit further and then get the tube over the top of it would be a really good thing to try. And I've given such a waffly answer, I can't remember what the second part of the question was.
Second part of the question was, what are the problems you might get when you're putting that tube over the top of the bougie?
Of course it was. Yeah, well, I think the most common one is when the tube is nearly all the way onto the bougie. You've then got the 22mm connector at the end of the ET tube that has a fantastic ability to then snag on the bougie. You then get that really awkward situation of trying to pass the tube over the top of it, sweat's pouring off everyone's forehead because nobody's quite worked out what's gone wrong, and then there's a huge tendency, isn't there, to then remove the connector. That goes flying across recess, never to be seen again, and you've got a tube that you can't use. So to save you that embarrassment, just straightening out the ET tube to then take it off the neck of that connector is something that will allow that tube to pass really easily. The second thing to mention, and I've only seen this a couple of times, is that sometimes in the excitement of the situation, then trying to pass the tube down, operator one can pinch the tube so hard that it actually gets snagged against the bougie. And there seems no logical explanation to why this tube won't go over this bougie. So just remember, if you do get into that situation, then just think about how hard operator one is pressing onto that tube, and then just maybe releasing that will help it slide over a bit more easily.